To unpack the viability of the scheme and where South Africa is at with it, I'm joined by Nicholas Crisp, the Deputy Director General in the National Health Department, responsible for the implementation of the NHI. Dr. Crisp, thanks very much for making the time to talk to us today. It looks like the pace of implementation for the NHI is picking up. The Treasury has approved 44 new posts for the scheme. What will those people do?
Yeah, thanks very much, Mia, and it's nice to talk to you. So indeed, we are putting the foundations in place for the administrative capabilities. If one looks at the NHI bill, there's a lot of work that needs to be done, a lot of preparatory work, and although it's a very long road, we need people to start drafting operating procedures. We need people to start drafting regulations that can go into the public space for consultation after the bill becomes law. And we need to start preparing the digital systems that are able to carry the work that needs to be done in the various areas of the NHI fund.
You've mentioned that these people will be technical people. What does technical be? What's the difference between that and administrative people?
So administrative people are people who look after human resources, finance, supply chain management, and so forth, whereas technical people are economists, public health medicine specialists, actuaries, lawyers, and people who will be doing the technical work, the drafting work, as opposed to looking after us and making sure that we are fed and able to drive around to do our work.
When will you start to advertise for these positions, and are there any more such positions that you're planning for, in addition to the 44?
So there's a business plan that was presented to the minister some time back, to the former minister some time back, that lays out the rollout over the next 5 years. But that is just to give us a picture of where we are going. And that, you can imagine, a very big running organization will need several hundred employees. Some of those functions already exist, and others of those functions will be completely new. But in the initial instance now, we have the approval from the Minister of Public Service and Administration to establish a transitional capability that will prepare for the entity, and we have authority from Treasury to use some of the money that had been set aside for preparing the National Health Insurance nucleus to spend on new conditions of employment. So we will commence with these 44 positions. We will inherit somewhere between 80 and 100 people and a couple of vacant posts from within the Department of Health who do functions that are described in the National Health Insurance Bill. And then once we have those processes well underway, we will then make a new submission to the Minister of Public Service and to Treasury to look at the next phase. But one doesn't want to run ahead of oneself. We need, over the next couple of weeks, we are hoping that the procurement process for the advertisements and the finalization of the advertisements are ready to go. And once that's in the public space, people will apply. We will do the necessary shortlisting, interviews, and the other processes that are required in the public service to recruit suitable incumbents to those 44 positions.
Timeline-wise, from what you're saying, it sounds like you are planning to appoint these people before the end of this year.
So in terms of the steps that are required in the recruitment process in the public service, some of these are very senior positions, so they have to go through various screening programs and writing of tests and goodness knows what. That does take time. So I'm not expecting that we will be making appointments before December. And it's highly unlikely that there will be people ready to commence duty before the start of the new calendar year. So hopefully we will have some of these 44 posts filled with incumbents to start work in the new year, while others will probably only join us February, March, and even into the new financial year.
Dr. Crisp, just for clarity, there's an NHI bill that still needs to be approved by Parliament, but we're already seeing new positions becoming available. How does this process work? Do we not first need the bill so that we have an act for the NHI to first be approved and then we advertise positions? Why are you able to go ahead with this at this stage?
So very good question, Mia. So there's been a lot of criticism that we have not informed people what are the benefits. I can't inform people what the benefits are because there isn't a bill and there aren't people to design those benefits. We can't even do the benefit structure, never mind the definitions of the benefits, so it's a catch-22. So what do you do and what don't you do? We need a digital system, whether it's an NHI digital system or whether it's an integrated platform for us to deliver health services in the country on the current format. So what is happening is that those positions in the 44 that are potentially vulnerable to specific NHI functions are going to be on contract positions, and those that are inevitable, whether there's an NHI or not, can be on permanent positions. And that is the condition of the funding from National Treasury. So we're not running ahead of ourselves at all. One might argue, why was I appointed as the Deputy Director General? Well, because somebody's got to lead the definition and design of the process. There's already a political process unfolding. You have to have an administrative process to be able to sustain whatever comes out of the parliamentary decision-making process. And whether it's delayed or not, we need to be ready.
So what would, for instance, happen if Parliament doesn't approve the bill, or if there's lots of court cases that prevent the bill from going through for a very long period? What will happen to these people who are appointed?
Well, as I said, there are some of these functions which need to happen irrespective. So with the digital system, where more than about half of the 44 posts are in that digital space, that needs to go ahead irrespective of what happens with an NHI bill. If one is now not needing to design benefits anymore because they're not going to be benefits, then those people are qualified to do other things for the remainder of their appointment period, and we'll see what unfolds going forward. You don't plan to fail, you plan to implement, and you need to be ready to adapt if things change along the way. We may end up with an NHI in a different form. We would like to end up in the form that we have envisaged it, but we may end up with something slightly different. But one thing is for sure, we need a better stewardship of the health system, and we need coherent systems to do that.
I'd like to move on to the issue of medical aids. The percentage or proportion of South Africans who can afford medical insurance, private health insurance, is admittedly very small. But they're very vocal, and one of their biggest concerns is that the bill currently suggests that their medical aids won't be allowed to provide the same benefits or services as the NHI. How will this be implemented? Is it in phases, and will there be still an interim phase where medical aids would be allowed in their current form? How will that work?
Yes, very much so. There'll be a transition period. You can't switch on reforms of this magnitude in a short space of time. We recently had an interaction with Japanese colleagues who told us it took them 34 years. And we know that other countries have taken up to 70 years to get where they are. The more recent ones have taken shorter because they know what to anticipate. So anything between 14 and 20 years would be a good time. So we have a very complicated system because half of our spending is in private money and half of it is in public money already paid through tax. But we also have other complicated channels of spending. So medical schemes at the moment cover about 8.6 million lives, which is a small fraction of South Africa. There's also quite a lot of out-of-pocket spending that happens of patients who are not on medical aids who get their care in the private sector. But there are also people on medical aids who run out of their medical aids and are then cared for in the public sector as well. We don't have accurate figures of those, but the actual figures are irrelevant compared with the proportions. So what needs to happen is during a transition period, of course, we need the medical aids to continue to provide coverage and to purchase health services on behalf of those who are their members. But the question is, do we need 76 medical aids with 250 plus different packages, or should we be standardizing packages and making the size of the risk pools bigger in a transition period and getting different ways in which we have transparency of what the benefits are? Because people want the public sector to tell them what the benefits of the NHI will be, but they have no clue what the benefits are that their own medical schemes cover them at the moment anyway. It's very fuzzy and very difficult to follow. And so in a transition period, one has to run both systems. So there won't be an instruction that in the short term, all medical aids will terminate. There's very clear indication in the bill, the wording, and maybe people would like to see it stated even more clearly than it is, that when the national health insurance is fully functional, only then will there not be a need for medical aids, and the medical aids will not be allowed to cover what is being covered by the fund.
The question that medical aid members will now, of course, have is, how long would that period be? How long can they still expect to have medical aids in their current form that cover all the benefits that they'd like and not exclude the NHI benefits?
Yeah, how I wish I had a crystal ball. In times of economic boom, it can be shorter, and in times of economic hardship, such as now, we probably need to go slower. So I can tell you that we're measuring in terms of years to decades rather than months to years in terms of their capabilities. We need to get the mechanisms and systems in place. We need to standardize the way in which we manage data. We need to make sure that we have interoperable patient records. We need a standardized patient record so that we can save on the duplications that we have both within the public sector and between the public and the private sector. There are many things that we need to put in place collectively before it is possible for us to move to there. And we showed that it's possible to do it under huge duress in COVID, but when there's less pressure and there's not COVID, and it's more complicated than dealing with one disease, it's likely to take us quite a bit longer. The good news is that we've shown we are quite capable of sitting around the table and working out these details between us.
For clarity, and to end with Dr. Crisp, during the interim period, will you require medical aids to align their primary healthcare package that they offer with the same benefits that the NHI offer in the public sector?
Well, the short answer is yes, that's where we would head towards. It's not an event again. We have seen a process to review the prescribed minimum benefits through the Council for Medical Schemes. That work needs to be accelerated and finished, but it needs to be harmonized with what we are doing in the public sector with the benefits package, particularly for primary healthcare. And we are doing it in stages in the public sector, so that is the starting point for us. So yeah, that is to harmonize that so that we all know that there's a common basis platform that everybody understands what it costs, what those benefits are, and how we can expect to get those benefits from our providers.
Dr. Nicholas Crisp, thanks very much for your time.